imagine this scenario. It is 11 p.m. The air is thick, humid,
Right.
and it smells faintly of antiseptic, maybe a little bit of rain. You are in a rural emergency room, perhaps a district hospital in India.
Or a remote clinic in sub-Saharan Africa.
Exactly. You are miles away from a tertiary care center. I mean, hours away from the shiny equipment and the vascular surgeons. The lights are flickering a bit because the generator is, struggling.
Right.
And then the double doors just swing open.
It's a scene that plays out thousands of times a year in the tropics. But the specifics of this moment are what turn a routine night into an absolute nightmare for the medical team.
Yeah. So a farmer is rushed in. He's supported by two frantic relatives. He was working in the fields late, maybe harvesting crops, and he was bitten by a snake 2 hours ago. You look at his forearm, and it isn't just swollen. It is massively distorted.
Just completely unrecognizable.
Right. It looks like a shiny, tight log. He is screaming in agony, a guttural, visceral sound that just cuts right through all the noise of the ER. You touch his fingers. They are pale, and they are cold.
That sensory detail is so crucial. The coldness, the pallor, it triggers an alarm in your brain immediately.
And right there, staring at this chaotic tableau, is the junior resident. They look up at you, the senior doctor, with just pure panic in their eyes. Because they've read the textbooks, they know the protocols, but reality is messy.
Very messy.
And they ask the question that really defines this entire deep dive into our source material today. They asked, do we give antivenom and wait, or do we cut?
Yeah, that question, to cut or to wait, it's the precipice.
Yeah.
It is the high-stakes dilemma where toxicology crashes headfirst into surgery.
The ultimate medical intersection.
Exactly. If you make the wrong call and wait too long, the patient loses a limb. The muscle dies inside the skin. But if you make a different wrong call, say you cut too early or without the right support, the patient could literally bleed to death on the table because the venom has turned their blood into water.
So today we are unpacking a topic that is, quite frankly, notoriously undertaught, but critically important for you to understand. We are looking at snakebite compartment syndrome.
And we aren't just talking about snake bites in general here.
I know.
We are talking about that specific, terrifying intersection where the venom causes so much pressure inside the limb that it threatens to kill the muscle and nerves from the inside out.
Right. It's the intersection of emergency medicine, critical care, and surgical intervention.
Yeah.
And the scary part we found in the sources is that the textbooks often get this wrong.
Or rather, they give you a sanitized version of the truth, a version that doesn't account for the nuance you need at 11 p.m. when the pressure is on and the resources are thin.
So our mission today, for you listening, is to move beyond the rote learning. We want to get into the actual surgical wisdom, the decision-making under intense pressure. We have a huge stack of fascinating source material here, research papers, surgical guidelines, case reports.
And it breaks down everything from the raw biochemistry of the venom to the exact angle of the surgical incision you need to make.
We're going to walk through the physiology, the diagnosis, this thing called the trap of the pulse, and the specific bacteria that eats limbs if you forget about it.
But we need to start by understanding the antagonist of our story.
The villain.
Right. Now, we know about the big four snakes in India responsible for most bites. You have the common crate, the saw-scaled viper, the Indian cobra.
And the Russell's viper.
Precisely. For this specific problem for compartment syndrome, we have a primary enemy, and it is the Russell's viper.
Why that one specifically?
Well, while cobras are neurotoxic and their bites are terrifying because they stop your breathing, the Russell's viper is a different beast entirely. It is hemotoxic and cytotoxic.
Meaning it goes after blood and cells?
It destroys the blood and the tissue. It is the core architect of the compartment syndrome we are discussing today.
Okay, before we get into the how of all this, let's clarify the what. Because I think most people have a vague idea of what compartment syndrome is. Maybe from a sports injury or a bad car crash. You break a leg, it swells, the pressure cuts off blood flow.
Right.
But the sources make it clear that snakebite compartment syndrome is fundamentally different.
It is, and understanding that difference is the absolute key to saving the limb. If you treat a snake bite like a broken leg, you might make a fatal error.
How so?
In a trauma case, like a broken tibia, the compartment syndrome is mechanical. The bone breaks, there's bleeding into the muscle compartment, the pressure rises, and it literally squeezes the blood vessels shut.
So it's a plumbing problem. Too much pressure in the pipes so the flow stops.
Right. It is purely physics, but in a Russell's viper bite, you have that mechanical pressure, sure, but you also have an active chemical enemy inside the gates.
An active chemical enemy.
The venom isn't just taking up space, it is a biological weapon.
Let's look at the dossier on this weapon then. What is in this venom that makes it so destructive?
It's a devastating cocktail. We aren't talking about a single poison. It's a highly complex mix of proteins and enzymes. You have proteases, phospholipases, hyaluronidases, and hemotoxins.
Okay, that sounds like a chemistry exam gone horribly wrong. Let's break those down for the listener. What are they actually doing to the meat and bone of the arm?
Think of them as a microscopic demolition crew. The proteases and phospholipases are enzymes that directly digest tissue. They are melting the muscle cells from the inside out.
Melting the muscle.
They break down the cell membranes, causing immediate necrosis. That's cell death.
So the muscle isn't just suffering from a lack of oxygen due to pressure. It's being chemically dissolved while it suffocates.
Exactly. And then you have the hyaluronidases.
Yeah.
These are often referred to in the literature as spreading factors.
Spreading factors. What are they spreading?
Well, think of the connective tissue in your arm as a series of walls or sandbags that keep fluids contained in specific areas. Hyaluronidase dissolves the mortar between those bricks.
Oh, wow.
It breaks down the connective tissue barriers, allowing the venom to spread rapidly through the tissue planes. It effectively unlocks all the doors so the rest of the toxins can just rush in.
So it's not just sitting in one spot where the fangs went in.
Yeah.
It is aggressively expanding its territory up the arm.
Aggressively. And while it's destroying tissue, it's also causing massive local inflammation. The body reacts violently to this foreign protein, sending fluid pouring into the area to try and dilute it.
Which adds to the swelling.
Yes. Plus, the venom disrupts the vascular endothelium that's the lining of the blood vessels, making them leaky. So you have fluid leaking out of the vessels and into the muscle compartments at a terrifying rate.
Okay, so unlike a broken leg where the swelling is mostly just blood from the break, here the swelling is a mix of edema, dissolved tissue, inflammatory fluid, and leaked plasma.
And there is a third layer to this catastrophe. The source material highlights that Russell's viper venom causes something called VICC, venom-induced consumption coagulopathy.
VICC. Let's unpack that acronym because it sounds like something you really don't want to have.
You definitely don't. Essentially, the venom activates the body's clotting mechanism appropriately, but it does it all at once throughout the entire bloodstream.
Wait, all at once?
Yes. It consumes all your clotting factors instantly. Your fibrinogen, your platelets, just gone. The result is disseminated intravascular coagulation, or DIC.
Which means the patient's blood effectively turns to water.
Effectively, yes. They lose the ability to form clots anywhere in their body. So now you have a feedback loop straight from hell. You have direct tissue destruction causing swelling. You have vascular leaks pouring fluid into the compartment. And because the patient has no clotting factors left, they are bleeding internally into the muscle compartment, which increases the pressure even further.
That is a double, or really a triple whammy. Mechanical swelling, chemical destruction, and internal bleeding.
And it happens incredibly fast. That's the core concept of time is muscle in these texts.
Time is muscle.
In a trauma case, you might have a bit of a grace period to decide what to do. But with snakebite, the venom is active. The texts describe cases where a patient walks in with mild hand swelling, and 3 hours later, the forearm feels like a wooden block.
A wooden block?
Hard, cold, lifeless. And by that point, the outcome is often grim. The venom doesn't wait for the surgeon to finish their coffee or for the shift change. It is totally relentless.
This brings us to the detective work. Put yourself in that ER. The patient is screaming. How do you actually diagnose this? Because I imagine the standard textbook signs might be misleading here.
They are worse than misleading. The sources warn they can be dangerous. In medical school, we are taught the 5 Ps of compartment syndrome: pain, pressure, pallor, paresthesia, and paralysis.
It's a catchy mnemonic. It's designed to stick in the brain. But why does it fail in snakebite cases?
Let's start with pain. The classic sign of compartment syndrome is pain. But have you ever seen a severe snakebite victim? They are already in excruciating pain from the envenomation itself.
Right, the venom itself hurts.
The venom burns. So saying the patient has pain tells you absolutely nothing. You have to distinguish the background noise of the venom pain from the specific alarm bell of compartment syndrome.
That sounds incredibly difficult in practice. How do you tell the difference?
You look for pain out of proportion, specifically on passive stretch. The source material refers to this as the absolute gold standard clinical sign.
Walk us through that. What are you physically doing to the patient to test this?
You take the patient's hand, let's say the bite is on the forearm, you hold their fingers, and you gently, passively extend them.
You're stretching the muscles.
You stretch the muscles that run through that swollen compartment. Notice you aren't asking the patient to move, you're moving the limb for them.
And if they have compartment syndrome?
They will scream. And I mean scream. It is a sharp, agonizing increase in pain that is totally distinct from the throbbing ache of the bite. If you passively stretch those fingers and the patient creates a scene, that muscle is ischemic. It is starving for oxygen. It is dying.
Okay, so the passive stretch is the critical test. What about the physical feel of the limb? You mentioned the wooden block earlier.
That's the sign for pressure. You palpate the compartment. In a normal limb, the muscle is soft, it's pliable, you can push into it. In compartment syndrome, the fascia, which is the tough casing around the muscle, is so tight that it feels tense, like a drum skin.
Like a drum skin.
We call it a woody feel. You literally cannot indent it with your thumb.
And you had to compare it to the other limb, right?
Always.
Yeah.
Comparing with the unbitten limb is key to detecting the difference early. You use the patient's own body as the baseline control.
Now let's talk about the trap. You mentioned pulselessness as one of those textbook 5 Ps, but our source material has a giant warning sign next to this one.
This is the pulselessness trap, and it is where junior doctors and sometimes even seniors get burned badly. There is a very common misconception that you should wait until the pulse disappears to diagnose compartment syndrome.
You hear people say, I can still feel the radial pulse, so the arm is fine, blood is getting through.
Yes, I can still feel a radial pulse, so the arm is fine. That sounds like a perfectly logical assumption if you don't understand the physics.
But it's wrong.
It is a tragedy waiting to happen. You have to understand the physics of blood flow here. The pressure required to kill the microcirculation, those are the tiny capillaries feeding the actual muscle tissue, is much lower than the pressure required to pinch off a major vessel, like the radial artery.
So the capillaries are the little side streets, and the radial artery is the main highway.
That's a great analogy. The pressure inside the compartment might be 40 or 50 millimeters of mercury. That is enough to crush the capillaries. The muscle stops getting oxygen immediately, it starts to die.
But the main highway.
Your systolic blood pressure, the pressure driving blood down the main artery, might be 120 or 130. That is strong enough to blast right through the local swelling and keep the main highway open.
So the muscle can be suffocating and dying while the main pipeline is still flowing and producing a pulse at the wrist.
Precisely. The pulse you feel is totally irrelevant to the health of the muscle tissue at that moment. By the time the pressure in the arm is high enough to completely stop the radial pulse, the muscle has been dead for hours. If you wait for pulselessness, you are merely documenting the death of the limb, not diagnosing a treatable condition.
That is a chilling realization. Diagnosis must be clinical, and it must be early. Now, if you are in a fancy hospital, you might have technology to help, right?
Yes, if you have the equipment, you can measure the compartment pressure directly. You stick a needle connected to a manometer into the muscle belly.
And what are the actual numbers we are looking for with that machine?
We use the delta pressure concept. It's much more reliable than a raw number because it accounts for the patient's individual blood pressure. You take the patient's diastolic blood pressure, that's the lower number on the BP cuff, and you subtract the compartment pressure.
Diastolic minus compartment.
Exactly. If that resulting number is less than 30 millimeters of mercury, you are in the danger zone. That means the pressure pushing blood into the muscle is barely overcoming the pressure squeezing it out. That is an absolute indication to cut.
But let's be real for a second. In the rural ER we started with, do they have this pressure monitor?
Rarely. And that's the reality check of the source material. In many district hospitals in India or anywhere in the developing world, you don't have the manometer. You have your hands, your eyes, and your judgment.
Right.
That's why mastering the passive stretch and recognizing that woody feel is so vital. You are the diagnostic tool.
So you've made the diagnosis. The arm is hard as wood. The patient screams when you move their fingers. You know the pressure is killing the muscle. Now comes the dilemma we teased at the very beginning. The toxicology team says, give antivenom, neutralize the poison. The surgical team says, cut it open, release the pressure. Who is right?
This is the classic chicken or the egg problem in this field. And the answer, unsurprisingly, is that they are both right. But they have to work in parallel. You cannot view them as mutually exclusive options. You don't choose one, you coordinate both.
But there's a massive complication here. We just talked about VICC, the blood turning to water. If you've got a patient who literally cannot clot, aren't you just killing them faster?
That is the terror of operating on snakebite patients. It is a genuine surgical nightmare. You make an incision, and normally you expect some bleeding that you can control with cautery or pressure. Here, every single tissue plane oozes.
It just doesn't clot?
It doesn't clot, it just weeps blood continuously.
Operating on liquid blood.
It's terrifying. It feels like you are losing control of the situation immediately. But here is the strategic thinking the sources outline. If the limb is truly threatened, if you have that woody ischemic arm, you cannot wait for the clotting to correct itself.
Because that takes time.
That could take hours or even a full day after antivenom administration to resolve. The muscle will be completely dead by then.
So you have to go in knowing it's going to be a bloodbath.
You go in, but you go in prepared. You operate while simultaneously resuscitating the patient. You are pumping in fresh frozen plasma, or FFP, cryoprecipitate, and platelets through the IV lines while you are physically releasing the pressure with the scalpel.
You're fighting the war on two fronts.
Exactly. The mechanical pressure in the arm and the chemical coagulopathy in the blood.
That requires incredible coordination. You can't just be a cowboy surgeon. You need the anesthetist and the hematologist on board. You need a highly communicative team.
Absolutely. And you need to know if your antivenom is actually working to reverse the venom's effects. This brings us to one of my favorite hacks from the source material. It's called the 20W BCT.
The 20-minute whole blood clotting test. It sounds very official, but the sources show it's actually incredibly low tech, isn't it?
It is the ultimate bedside hack for resource-limited settings. You don't need a lab, you don't need a technician, you don't even need electricity. You just need a clean glass test tube.
Walk us through the procedure. First off, why glass specifically?
Glass acts as an activator for the intrinsic clotting pathway in the blood. If you use a plastic tube, it takes much longer and the result isn't accurate. So you draw 2 milliliters of venous blood from the patient. You put it in the glass tube, you hold it upright, and you wait exactly 20 minutes.
You just leave it alone.
Don't shake it, don't agitate it, just let it sit undisturbed.
And
then, right at 20 minutes, you tip the tube.
Yeah.
If the blood is solid, if it has clotted and stays at the bottom, then the patient is safe, or at least their clotting factors are functioning enough. If the blood runs down the side of the tube like water, completely liquid, then they have coagulopathy.
It's totally binary, liquid or solid.
Correct, and it tells you immediately if you need to give more antivenom. If you've given 10 vials, waited, and the blood is still liquid at 20 minutes, you need more antivenom.
Yeah.
It's a brilliant zero-cost tool that saves lives every day. It removes the ambiguity.
I love that. It empowers the doctor in the middle of nowhere to make sophisticated life-saving decisions with a simple glass tube. Now let's get to the most controversial part of our deep dive today. To cut or not to cut. The procedure is called a fasciotomy, slicing open the fascia to release the pressure.
This is where the wisdom really comes in. Years ago, the teaching was very aggressive. The mantra was, if in doubt, cut it out.
If the arm is swollen, do a fasciotomy. Right. The logic was, why take the risk of the muscle dying? Just open it up. But the expert opinion in our sources has swung drastically. Now, the overwhelming stance is cut with extreme caution.
Why the massive shift? If the pressure is high, shouldn't releasing it be the obvious immediate answer?
In trauma, yes. If you crush your leg in a car door, the muscle is inherently healthy, but it's being squeezed. You release the pressure, the blood flows back, the healthy muscle survives. But remember our antagonist, the Russell's viper venom.
The chemical weapon.
Right. In snakebite, a large portion of that muscle might already be dead, not from the mechanical pressure, but from direct toxicity. The venom melted it.
So releasing the pressure won't bring it back to life.
Exactly. You can't resuscitate steak. If the muscle is necrotic from venom, cutting the fascia doesn't save it. But what it does do is open a massive surgical wound in a limb filled with dead, jelly-like tissue in a patient who cannot clot.
You are creating a giant entry door for bacteria.
Precisely. You are turning a closed, sterile injury into an open, bleeding, highly infection-prone disaster zone. That wound becomes a setup for catastrophic infection and secondary hemorrhage. So doing a fasciotomy when it wasn't absolutely necessary can actually be worse than doing nothing at all.
It introduces iatrogenic harm caused by the healer.
Exactly.
That is a very heavy responsibility. You really have to be sure. So what are the absolute must-do indications? When do you finally put the knife to the skin?
The guidelines lay out 4 distinct scenarios where you must cut. 1, establish vascular compromise. The pulse is actually gone. The hand is white. You have to try to save whatever is left.
Okay, that makes sense.
2, you have that manometer and the pressure is clearly and consistently above the threshold, that delta of less than 30 millimol Hn.
And 3.
3, rapidly progressive neurological deficit. And the patient is actively losing sensation or movement right in front of your eyes despite treatment.
And the 4th scenario?
Failure of medical management. You've given adequate antivenom, you've elevated the limb, you've done everything right, but the swelling is still getting worse and the clinical signs are deteriorating. The overall trend is wrong.
But the key takeaway for you listening here is no prophylactic surgery.
Never. You never do a fasciotomy just in case. The knife is not a safety blanket for the surgeon's anxiety. It is a specific tool for a specific measurable problem. If you cut prophylactically in a snake bite, you are introducing massive risk with absolutely zero benefit.
Let's say you are in that situation where you absolutely must cut. The indications are clearly there. This isn't just a simple, quick slice, is it? Precision really matters.
It matters immensely. A bad fasciotomy is completely useless. Let's talk about the upper limb first, specifically the forearm, which is the most common site for these baits.
What's the most common mistake junior surgeons make here?
Doing a single small incision. They make a cut on the volar aspect, the palm side of the forearm, and they think, okay, I've released the pressure, I'm done.
But the forearm isn't just one big balloon inside.
No, it's a very complex structure with 3 distinct compartments. The volar, the dorsal on the back, and the mobile wad on the side. The venom spreads everywhere. If you only release the front, the back is still being actively strangled to death.
So what's the architectural fix for that?
The incision must be extensile. That means it goes all the way from above the elbow down across the wrist. It looks incredibly gruesome, but it's anatomically necessary to release all the deep structures. And you very often need a second separate incision on the back of the arm to release that dorsal compartment.
You basically have to unzip the whole arm.
Essentially, yes. And don't forget the hand. The hand has tiny muscles. The interossei, the thenar, the hypothenar eminences, they're all trapped in their own little tight rooms. You might need separate delicate releases just for them.
Now let's switch to the leg, the lower limb. There's a specific trap here that our expert sources really highlighted, the deep posterior trap.
This is the classic rookie mistake in lower limb fasciotomy. The lower leg has 4 distinct compartments: anterior, lateral, superficial posterior, and deep posterior.
And which one inevitably gets missed?
The deep posterior. It's buried deep inside, behind the massive calf muscles and right up against the shin bone. It contains the muscles that curl your toes and move your foot downwards.
Why do surgeons miss it so often?
Because when you slice open the calf, the big superficial muscles just pop out and it looks like you've done a great job. The tension feels gone, everything looks loose. But behind them, deep against the bone, that 4th compartment is still tight as a drum.
And if you leave it?
The deep muscles die. The patient survives, their leg is saved, but they develop a claw foot or foot drop. They completely lose the ability to push off when they walk. It's a permanent, life-altering disability, all because the surgeon simply didn't go deep enough during the release.
That is an incredibly powerful lesson in anatomy. Half measures are worse than no measures.
Correct. If you are going to commit to cutting, you must do a complete 4-compartment release in the leg. Otherwise, you've just given them a horrible surgical wound and a dead leg anyway.
Okay, so the surgery is done, the pressure is finally released, but the battle isn't over. Post-op management in snakebite is notoriously tricky.
It is. Rule number 1 in post-op: never, ever close the wound primarily.
Why? You've got this massive open wound running down the arm. You want to close it up.
Because the swelling hasn't even peaked yet, and the tissue inside is still declaring itself. Some muscle might be totally dead, some might just be stunned and recovering.
Wow.
If you stitch it closed immediately, you'll just create compartment syndrome all over again as it swells, or you'll lock in a massive infection with the dead tissue.
So you just leave it wide open.
Yes. You dress it carefully, keep it clean, and wait, usually 5 to 7 days. Then, once the swelling is definitively down and you know exactly what tissue is alive and what is dead, you can do a delayed primary closure or put a skin graft over it.
And during that 5 to 7 day waiting period, you're looking for that dead tissue.
Serial debridement. You take the patient back to the operating room every 48 hours. You carefully trim away the dead muscle. You don't try to be a hero and cut it all out on day 1 because you might accidentally cut out stunned muscle that could have recovered. You wait for the tissue to definitively declare itself dead.
No, there is a hidden killer lurking in these open wounds. Something very specific to snakes that the sources brought up.
This is a microbiology pearl that absolutely saves lives. A snake's mouth is a very dirty place. It's full of specific environmental bacteria, but there is one specific bug that loves snake bites, Aeromonas hydrophila.
Aeromonas hydrophila. Why is it so bad?
It is intensely aggressive. It causes rapidly spreading necrotizing fasciitis. That's what people commonly call the flesh-eating disease.
And I assume standard everyday antibiotics don't touch it.
Many of the standard first-line antibiotics we routinely use for skin infections are completely useless against it.
So you have a patient who survives the venomous bite, survives the bleeding, survives the massive surgery, but then their arm starts turning black and rotting a week later because the doctor used the wrong antibiotic.
Exactly. The core lesson is, if a snakebite wound gets infected fast, you must assume it's Aeromonas and cover them with broad-spectrum antibiotics specifically targeting it immediately.
And finally, rehabilitation. It's so easy to forget about rehab when you're just focused on saving a life. But for the farmer who needs to go back to work to feed his family, this is everything.
Physiotherapy must start on day one. Even while that massive wound is still open, you have to keep the joints moving. If you let that hand sit perfectly still for 2 weeks while the skin heals, it will freeze solid.
The tendons get stuck.
You'll get severe contractures, stiff, useless claws. You successfully saved the limb, but you totally lost the function.
Save the life, save the limb, save the function.
In that exact order of priority.
Let's bring this all home with some real wisdom from the OR. Our source material provided 3 distinct case studies that really illustrate these points beautifully.
These stories are the kind that really stick with you long after the reading is done.
Case 1, the cost of waiting.
This was a Russell's viper bite. The surgeon saw the patient, noted some coagulopathy, gave the antivenom, and decided to watch and wait. But he waited far too passively. He checked the patient, then maybe went to do rounds or get some sleep.
And when he finally came back,
Massive swelling. When they finally operated, they found gray, non-contractile muscle, dead muscle.
so the lesson there, reassess every 30 to 60 minutes. The venom moves much faster than standard hospital rounds.
Exactly. You can't put these patients on a normal schedule.
Case 2, the Aeromonas nightmare.
Scenario here was a cobra bite. They had a successful surgery, released the pressure early, but there was no specific antibiotic cover prescribed for Aeromonas.
And the outcome was necrotizing fasciitis,
Right.
leading to a near amputation of the limb. Lesson, always cover for Aeromonas hydrophila when dealing with snakebite wounds.
How fail?
Case 3, the triumph of restraint.
This is an important one. Scenario: a saw-scaled viper bite in a child with a very tense hand. The junior resident desperately wanted to cut. They saw the tension and panicked.
But the action taken was different. The senior surgeon checked carefully. The pain was not agonizing on passive stretch, and capillary refill was present. They gave antivenom and just waited.
And the outcome? The swelling naturally subsided, and the child's hand was saved without a single surgical scar.
Lesson, the wisest surgical decision is very often the one where you keep the knife in the holster.
Knowing when not to cut is the hallmark of a master surgeon.
So let's do a rapid-fire recap for you listening. I'm going to throw the questions at you, and you give me the deep dive answer.
I'm ready.
Best bedside test for clotting.
The 20-minute whole blood clotting test in a glass tube.
The critical clinical sign that tells you to operate.
Pain out of proportion on passive stretch.
The compartment everyone misses in the lower leg.
The deep posterior. Always, always check it.
The bacteria to fear the most.
Aeromonas hydrophila.
This has been an incredibly eye-opening journey through the material.
It really connects to the bigger picture of critical thinking in medicine. Whether you are a surgeon or a CEO, you are often faced with data that is incomplete. You have textbook rules, but reality breaks those rules. You have to adapt dynamically.
And that leads us to our final thought for you to ponder. We've talked a lot today about the pulselessness trap, waiting for a sign that is so obvious it means you are actually too late.
It's a very powerful metaphor for life and business.
So here's the question for you. In your own field, what is the equivalent of the pulse you are waiting for? Are you waiting for a project to completely fail before you intervene? What are the subtle early signs you're equivalent of the passive stretch pain that you are currently ignoring?
That's a thought that might save more than just a limb.
Thanks for joining our deep dive into the sources today. Stay curious, watch where you step, and remember, think logically, think surgically.